One step forward, it is two steps back. You cannot go back up again and start. You again go through that same progression. So it's easy to lose and takes time to gain. Any one decompensation is all it takes, after which again you lose and you need to come back. So when they come to you for rehab,
training and mini squats, lunges and all of that. So any protocol regarding the strengthening, because after that she's quite a lot better with climbing stairs when she's traveling, or when she goes for a work related things. So she's been able to manage and pull off well after the strengthening exercise. But is there any limitation or any
So from guidelines, no. There is nothing that says there's a ceiling for it. We have progressed well into, as long as, so our dogma generally what I tell them is, if your patient is comfortable, do. So push, it doesn't matter. You may need to initially, when you go up on weights, reduce the repetitions, reduce the sets. So I tell the patient that it's not that you're doing worse. It is that if I'm going up from, I've been making 2.5 also, I suddenly I'm taking you up to 2.5. I don't want you to do the same amount. I would rather have you do one set 5 repetitions and stop for the day, rather than having you do multiple sets. And then I will do that again at that point. So that could be one option, that you reduce the frequency, reduce the sets when you go up, and then again keep going up. So major changes, if you actually see them struggling when they, when you shift to a higher weight, then you see them struggling.
या शुभ्रवता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करं प्रभुजी वन्दिता सा मा पातु सरस्वती भगवती ईशे सजाड्या पहा ईशे सजाड्या पहा.
First of all, a warm welcome to our KM Hospital, and our physiotherapy department is one of the very active department, and they have all subspecialty also developed. So I congratulate them and Maria and all that. They are really the very fact that so many people have come for such a focused group itself shows that this how much success they are going to. They are going to be good teaching material. That's why all of you have come. That's the thing. So I think cardiac rehab is really important, because my husband is a cardiologist, and often we used to think in the past that we should have our own clinic, and that time we used to think we must have a cardiac rehab person in that clinic. We have not yet had our own clinic, but the hota tha, often after a MI, many people require guidance how to go further, and they hesitate asking the cardiologist, who is always so busy, who always wants to do angiogram and angioplasty and not answer the routine questions. So for them to go to a physiotherapist and have a gradual build up of the activities is, I think, very important, and that's where I think all of you come into it. The last I had for her, it was our heart transplant patient, and she was there 3 times a day, and the relatives told one of the reporter that madam has given us time to time what to do. The reporter asked me, who has given this? I said, yeah, there is one lady who is a therapist who has given this. So she said, I have to speak to her. So then I think we spoke to her. Yeah. So I think even when in dementia, like I'm a neurologist, when you give a structured program, it makes a lot of difference to the patients. So structured program for any rehab is very important, and that's where I think just we tell them आज 10 कदम चलना, कल फिर 20 कदम, इससे नहीं होता है. But सुबह से शाम क्या करोगे? If you tell them, I think that is important. You tell your patients, spend a little more time and give them a whole day program. So then patients are more set, not confused, and they know what to do whole day. So I think that structured program we should always learn how to give it to as per their cardiac efficiency. And I'm sure, I think we cover asthma also. Yes. Cardiovascular. So I think definitely the asthma is another chronic disease which never goes once it comes. So I think your breathing exercises and all will also make a lot of difference to the patient's life. So So congratulations and once again thank you all, and thanks for coming, and I'm sure you're going to have a good academic feast in next 1 week.
And even also as an assessment that stands out as a very prominent tool to assess how the symptoms and his overall functional level and his condition is improved.
And what was the RP when you say government scan is always higher compared to what is but the desaturation is not.
And even so there are XCID in COPD patients for permanent circulation.
Issues like back pain or knee pain. So that also is a challenge for them to complete that test. So we may get a false positive or something.
So coexisting.
Coexisting. And so most of the time in our first interaction with the patient, we are not able to evaluate the stress as well because he's too listening and rest as well. So like most of our patients in the first interactions, most of
Environment and how you provide the care partners. Same thing.
Not exactly that. Here, what we want to do.
Same thing, we've been seeing a lot of heart failure patients with PAH, and we are doing cardiac rehab. So how cardiac rehab will help in these patients, and how the PAH parameters will help.
I'm Niharika Sutta, I'm 31 KM. I want to gain knowledge about pulmonary hypertension and of course about the do's and don'ts while treating the patient.
Which is a place called Malpe. So it's primarily a fishing area, and very enthusiastic man. He came with severe functional limitations, came to us for rehab. In 3 months, he was doing so well. He became our champion for us in that area. He would go find people who say, you can't walk, you can't say, come. And he'll bring them to us. I'm going for exercise, you come with me. So then we used to take them, get him evaluated by the cardiologist, and then we find out, oh yeah, they also need. And he used to take them for walks in the beach in the evening. He would say, come with me, I'm going for a walk. Walk as much as you can, because he stayed with us, you won't believe it, for a year. Okay? The only drawback with him was that he was over enthusiastic. So he would never report symptoms when they actually happened. So we had one treadmill that was facing a window. I had a table sitting this side. So I had finished some work. He was on. He'll come in and do, good morning, sir, how are you? And then he'll just start off. He'll do his warm up, he'll do everything. You very rarely have to keep an eye on him because he knew exactly what he was doing. One day he came, he sat, did all of this. I said, are you alright? You're looking a little down. He said, no, I'm fine. I can sleep well at night, that's all. But I'll exercise, I'll be okay. I said, okay, go ahead. So much so we had become complacent rather, with even our routine evaluation, because he comes and he does and he goes. Okay. He got on. So I was sitting and writing something, and suddenly I looked up at him and I see his neck suddenly looking a little different. He used to remove his shirt and walk on the treadmill. And I noticed distension in the neck. And I asked him, are you alright? And he's not answering me. So we had no monitoring. I immediately walked up, auscultated his back, and I can hear fine crackles all the way up to his shoulder. And then when I looked at his neck, I can see his JBP all the way up, which has never been there all this while. Stopped the thing, auscultated with a loud S3 gallop, put him down, made him sit, called the cardiologist. They gave him one shot of Lasix. It all settled down. The good thing was he didn't require admission, but a lot depends on what you observe, what you see. So these signs, a third heart sound, you may curse those who are doing masters would get really annoyed with your faculty to tell you auscultate. You can't quantify that speed. Okay. Anything else? Even in an OPD with some of these speakers you claim to be fantastic speakers, patients have said, I can't hear the beat. Okay? And I've seen people do it with, they walk beside with their phone in their hand and then wait till they hear the beep and then walk back again. So these are challenges with the incremental shuttle. But nevertheless, it has been used. There is a lot of data on the incremental shuttle in PAH for prognosis. It's as good as some of your variables from CPET. It's as good as what the 6-minute walk does. And this has been primarily used in the UK, whereas the rest of the world is still using 6-minute walk. So the British always like to do something different at most.
I don't do the count, like how many counts of spot marching they can do. It's just if they can sustain for 1 minute, do the spot marching. But again, the issues which I face is if there is desaturation, which is happening, what shows on 6-minute walk test doesn't show very well on a sit-to-stand or a spot march. The desaturation is not clear when we are doing the 1 minute sit-to-stand and spot march. For sit-to-stand, I get the count also. So how many sit-to-stands they have done it in 1 minute. So that's like an outcome measure for me because after maybe 6 weeks of rehab, maybe I'll come to know if there is a change, which you see. And this is more functional. I get a change. 6-minute walk test in 10 patients, I don't get a change. But sit-to-stand, spot marching, I get a change. Sometimes do the arm curl test also. So that gives me a change.
Peripheral vascular resistance does not contribute to that extent to right ventricular function as it does with pulmonary vasculars.
But
It's
still,
that correlation.
inability to work, what exactly was the work?
Okay, that is, those are, so
Yes.
they're not.
Frequency, intensity, time and type of exercises would be determined. The frequency would be somewhere around 5 to 6 times days per week, and the intensity would be to start initially because there's a PSP of 112. We would start very mild intensity exercises where we would be targeting later, I think, for a
The first beginning is start from the 5 minutes where we exercises and so that whatever the highest PSP level that is, and the taxi showing continuing the techniques the practice will follow. The rectal venous colon should not get overloaded. So those kind of exercises are prescribed.
Any? So yeah, I think most of it is fine, 5 to 6 days a week, starting with mine. Probably I think, yeah, you would start with free exercises, start maybe even at lower time points, 5 minutes.
which the patient has come. Then the medical history, whatever it is there. Plus in the history it is given L5 and S1 disc prolapse. So a little bit narration about what exactly the level of pain or what currently it is will happen in the active phase. So that accordingly we can plan out the evaluation test. So that was the first thing. Then lastly, we will start with patient education, wherein we will educate the patient, caregiver, and the family members. So it will include everything about the condition, why he or she needs to exercise, and the possible advantages and do's and don'ts and red flags. So next, the L5-S1 disc prolapse. So the patient will be having pain also. Like pain would be a prominent symptom, assuming that pain is, which could include modality and exercises. So starting as the patient is 50-year-old, so we could start with active and free exercises at the start, and aerobic training the patient progresses, and respiratory muscle training.
So
Now with the L5S1 pain and resistance training focus on upper leg.
yeah, it will be primarily upper.
In a very short duration, we'll start from that, and then as his duration at RP improves, reduces, we can progress to more. And if he's exercising in our OPD setup, so maybe the treadmill, or if he has pain, consider the L5S1, we can start the recumbent cycle. So considering the RP, how many repetitions, how many RPMs he can do, or how much minutes he can do, we can start with that and then progress based on RP, because that is the easiest thing to
If there was a
understand.
CPT done prior, and based on that value we can
Stagnant at a level. 2 weeks gives the patient sufficient time to get used to it. 1 week sometimes may be too short. Because if they are doing only 3 days a week, you need to give the body sufficient time to get accommodated to certain.
So evaluation of 78-year-old COPD patient with cold pulmonary and PVD, severe pulmonary hypertension on echo and severe obstruction. First, history. In history, we will focus on chief complaint. Look for. We will also ask for further detail. Like if for PVD there is no Doppler mentioned here, so we can also assess ABI. Then look for general examination, that is vital